make today, health sector reform in Ghana, is based on a research project that myself and my colleagues, Dean Liu and Jeff Everett, have been working on for the past couple of years. Our objective in that project is to look at how accounting is informing deliberations on health sector reform in sub-Saharan Africa, taking the case of Ghana as an example. Now, in this presentation, I'm just going to make sure that I don't take you into any of the details of accounting. That was our primary objective for doing this research, and in fact, the public forum today is informed by this project. So I will eliminate all the accounting details and focus on the macro level policy issues over a 3-decade period.
Can you speak up? Okay, we're having trouble hearing you back here.
This is actually the first time that someone will complain about me being too loud. Okay, I'll present you with an outline where the presentation is just going to come in 2 parts. The first part will look at health sector financing in Africa more generally, and then look at the reform processes that took place in Ghana over a 3-decade period before some reflections are provided. Now, health sector management is increasingly becoming a challenge in most countries around the world. From the economic powerhouses like the US all the way through to the less powerful African countries, we find that there are ongoing debates about how to effectively manage the health sector. Now, if we take the case of sub-Saharan Africa, the situation there is more critical for a number of reasons. But if you look at hospitals in sub-Saharan Africa, they are simply overwhelmed by the demand for the level of services. In fact, demand that is exacerbated by the HIV/AIDS crisis, the malaria crisis, and the tuberculosis crisis. Now, because of the level of stress that we have on hospitals in sub-Saharan Africa, in the year 2000, the World Health Organization called for an intervention, external intervention in sub-Saharan Africa to help improve the level of services that hospitals provide in these countries. Now, since that call was made, a number of powerful global agencies like the World Bank have been attracted to that region to help with improvement in the health sector. They have been particularly the funders of most of the reforms that are occurring in sub-Saharan Africa today. Internally, the governments of sub-Saharan Africa have also taken up the challenge. In fact, in 2001, a group of African head of states met at a summit in the Nigerian capital, Abuja, where they deliberated various ways of improving the health sector in sub-Saharan Africa. Like Stephen Lewis, I do have a problem with some of the outcomes that they had at that summit. One of the primary recommendations that they made was to improve the level of funding of health sector in Africa, bringing it up to the level of about 15% of GDP. So here was a problem that hospitals were literally dying, and to tackle the problem, they thought funding was the main issue. Now we're going to come to see how maybe funding might not be the one. It was perhaps a misdiagnosis. Now, starting off with health sector expenditure as a percentage of GDP, since the year 2001, when the target of 15% was set, not even a single country comes close. By 2005, this was the picture that we had. In fact, this is the top 15 in sub-Saharan Africa. As a percentage of GDP, Malawi came in at 12.2 and Mali 5.8. These are the top 15. If you look at the bottom half, some of them have about 1.5% of their GDP devoted to health sector allocations. Now, my problem with the use of GDP, and again, a lot of our speakers here would agree to this, my problem with the use of GDP as a target for improving the quality of health services in sub-Saharan Africa is, if you have peanuts as the base, and you're talking about 15% of peanuts, honestly, you're not going to get anything better than peanuts. And the picture that we have here is describing it. If you look at all those that are in yellow, they're talking about per capita income of less than $5,000. That is, if you look at the gross domestic product divided by the number of people that inhabit that particular country, we're looking at about an average for sub-Saharan Africa of $3,500. 50% of $3,500 is not going to take you too far. And we're going to come to see how these things play out in terms of how the impact that it has on hospitals in sub-Saharan Africa. Another way that some people have argued is to look at percentages of budgetary allocations. What proportion of a country's budget goes towards the health sector? For me, all those metrics that we use for evaluating the quality of healthcare are questionable, and we're going to look at those shortly. Now, in terms of looking at the per capita GDP as a basis for healthcare funding, if we put Africa within the global context, it becomes more pronounced. The situation becomes more pronounced. All the brighter colors are the ones that you're trying to avoid, the reds and the yellows. And all those are found in Africa, with the exception of South Africa, which comes close to the green, which the rest of them are, in fact, where you want to be are the darker blues and the lighter blue areas. And none of those you would find in sub-Saharan Africa, which speaks to the fact that the level of funding really is low, but there could be a lot more to it than just funding. That's the point that we are making in this project. Take the case of the US, you have about, the darker blue there suggests that they provide up to about 8,000 per capita. If you look at some sub-Saharan African countries, you're going to come to look at those, they provide about $15 per capita for healthcare. Again, looking at the macro, this is how much they provide. It is important to break it down into what is publicly funded and what is privately funded. That way will make a lot more sense of it. Now, what we have there, if you look at the case of Nigeria, they provide, in terms of healthcare expenditure per person, they provide about $90 per year. Of the $90, about 75% is privately funded. This is out of pocket from individual patients. Take the case of Eritrea, where they provide about $10 per person. Of that, about $3 is what the government funds. The situation is really dire. Of course, Ghana stands out in that case, if you look at it. Although Ghana provides about $58 per person, about half of it is publicly funded, which is a situation that is resulting from more recent reforms that the government has put in place, where they have moved from a price system that was based on cash and carry, I'm going to come to that, and moving towards an insurance, a health insurance policy system. So these are some of the situations that you will find in terms of health sector funding in sub-Saharan Africa. Now let's see how this affects some of the outcomes. If you look at life expectancy, in countries like Canada, you're talking about 78, 79, 77, something like that. Globally, the bottom 15 actually happen to be coming from sub-Saharan Africa. And that is what you have there. In the case of Swaziland, which is ravaged by the HIV/AIDS crisis, life expectancy, if you were born today, you can only count on 32 years, and you're gone. Nigeria, a very large country in sub-Saharan Africa, with 48 as life expectancy. So clearly, there is a problem here. We're talking about the level of funding as a problem, but if you look at how it cascades down to the impact that it's having on lives, it is huge. Another metric that we can use is the physician per 1,000 persons. In countries like Canada, you're looking at 2.1. For every 1,000 people, about 2.1. In the US, about 2.3. In sub-Saharan Africa, if you look at the entire world, the bottom 15 countries, I think it's only Papua New Guinea, which is not an African country. The rest of them are from sub-Saharan Africa. But in situations like Sierra Leone, you're looking at about 0.3. So that for every 1,000 people, they can only count on 0.3 doctor. This is a very, very dire situation. So now this gives us the context in terms of where the research took place. What we did then was to look at, after this macro level analysis, what we did then was to look at a case study of a hospital and see how that hospital is impacted by some of these funding issues. we took a teaching hospital in Ghana called the Tamale Teaching Hospital, and those are some statistics that you have on that hospital. It serves about 350 people in one of the major regional capitals with 13 districts. So population-wise, you're looking at about 500,000 people that this hospital is servicing. And it was established in 1974 with a capacity of 380 beds. Now, as of August 2010, last year when we went and did some more interviews at this hospital, the number of doctors that they had was about 78, and the number of nurses was just over 400. And it is located in the northern regional capital. And given its location in the north, which is not economically viable, a lot of doctors find it very unattractive to locate in that region. So there are unique problems to this particular hospital. Since this hospital was established in 1974, it hasn't seen any renovation whatsoever. No major renovations have occurred, and I'm going to show you pictures of the hospital. That's the front view of the hospital. The CEO and others are in the bottom end there, and the operation theater is up there. You might look at the outside and go, wow, that looks a little dilapidated. You have to take a look at the inside. That's the back view. The rear view there with the maternity ward highlighted right there. And again, you literally have to visit the inside of the maternity ward, and you will find serious crisis. Because literally you have people that are ready to give birth, sitting on the floor waiting for the midwife, and the midwife is dealing with 10 people at the same time. She just can't do it. She just can't do it. So in fact, on one of the occasions that we went in for interviews, it was a very sad situation to be seeing people going through childbirth openly in the corridors in the maternity ward. That is why I think when I took this photo at the back, I was like, yeah, this is something that will tell the story. Now, what has the government been doing in Ghana to govern the health sector? I would like to start from the time that the country got political independence from Great Britain in 1957. Now, the then government, the post-colonial government, inherited a system of healthcare that was universally free to patients. You walk into the clinic or the hospital and you would be seen by a doctor, and all the necessary medication will be provided free of charge. Now, this was something that they inherited from the British colonial administration. It was common in most former British colonies in sub-Saharan Africa. But the country witnessed a very long period of political instability. Starting from 1966 all the way to 1981, there was one military regime after another. As a result of this, a lot of these military regimes did not pay particular attention to the health sector. And the level of investment in the health sector was woefully inadequate. During the free healthcare system, it was very common to see things like this happen, pictures like this. You have the hospitals were almost full on a daily basis because people would come if they had any illness. They would not hesitate to show up, and the government was fully funding this, so there was no problem at all. In fact, in the part of the country that we did this research, one of the interview respondents was telling us, says, there used to be a case where if you went to the hospital, they will not only give you the consultation, but they will also provide you with medication. So there was one time that a lady went to the hospital, came back home, this was a pregnant lady, came back home with some medication, and then said to the husband, look, the doctor says I should have all these medication, and in addition, the doctor also suggested that I should have some liver and stuff like that that will help with my nutrition. And the husband asked, so where's the liver? Obviously, the husband was expecting that if the doctor is able to prescribe you with all this medication, it is his responsibility to provide you with the liver as well, to improve your nutrition. These were expectations that people had, just to put it in context. And they will literally come in their numbers with any illness at all that they have, including people coming from rural areas. Now, following some serious economic crisis that the country faced, in 1985, Actually, starting from 1981, the country was going through some serious economic crisis, and as part of the economic recovery program that the government at the time suggested, which was funded and supported by the World Bank, they introduced what they call structural adjustment programs. And with the structural adjustment programs came a new policy that emphasized cost recovery, introduced in 1985. Here was a situation where patients were now expected to pay for the services that were rendered by hospitals. Initially, this was the idea was to recover about 15% of the cost of providing these services, but this went up to full cost recovery within, I think, about 2 years, they said. Now, the health sector became one of those areas that was affected by the sweeping reforms. This was cutting across various sectors in the country. Ghanaians were now expected to pay for their health care, and what was the effect? In rural areas, we still had, this is a rural hospital under the tree. The doctor comes once every while, and then people come together, like they are waiting there for the doctor under a tree. During the healthcare recovery system, the cost recovery system, we still had people lining up under trees like this in rural areas, expecting the doctors to visit. The idea was that they receive their treatment and then make payment afterwards. So they didn't have a problem with it. In the urban centers, again, there were people lined up waiting for doctors. Now, there was a problem, however, with the health care cost recovery policy. People would still show up in their numbers, receive the treatment from doctors, but when the bills are sent to them, this is where the problem arises. They say to them, hey, look, you know I live on less than $1 a day. How am I going to be able to pay for this? So the hospitals across the country experienced a situation where they were mounting bad debts. There were attempts that were made to collect these debts, but they just were not successful attempts. So what did the government do in response to this? In response to this, in the early 1990s, the government realized that hospitals were under a lot of stress because they were not able to generate the necessary funds from the cost recovery policy to be able to fund their operations. Therefore, the government came out with yet another policy, cash and carry. Here, you are now supposed to pre-finance your healthcare. You come into the hospital, your first point of contact is a revenue collection department. You go to the revenue collection department, pay for your services, then you see the doctor, and then it takes on from there. Any treatment at all that was supposed to be given to you, you have to pay for it before it is given. What was the problem with this one? The bad debt issue was resolved, because people will no longer have the opportunity to come in and then have the services rendered to them first before they make payment. You come in, if you don't make payment, they don't see you. That was just the bottom line. So a lot of people took alternative routes. What we see there is African traditional medicine, particularly in the rural areas. That was the option, because this is very cheap. All you have to do is, in the photo to your left or the other side is a diagnosis that is going on. What the person has to do there is to do an investigation. Even you don't really have to be present when this diagnosis is done. You don't need a CAT scan. The patient doesn't have to be present. This guy goes there, sits, and then he does all his things, and then comes out with a recommendation in terms of what the particular sickness is and how it should be tackled. In the other photo there, we see this guy that is preparing the medication. The patient doesn't really have to be there. At the time that the patient is supposed to be there is when we are administering it. Obviously, as you can tell, if you are diagnosing someone without them being present, medication is done without them being present, it's only when the administration is done that the patient has to be present. The situation was very bad, particularly in the case of malaria cases. A lot of cases that were brought to the hospital they came in at the time that it was too late. And the malaria deaths were very high in that country during the cash and carry system. Now, because of the lack of internally generated funds from these hospitals, hospitals were under a lot of stress financially, and budgetary shortfalls persisted even with the cash and carry system. And civil society organizations rose up, like the NGOs. We cannot see our people dying in these numbers. So they confronted the government. There were massive demonstrations about the healthcare system. In fact, this also coincided with a period where the country was becoming democratic. In fact, in today Ghana is seen as a model democracy in sub-Saharan Africa. That was why President Obama made it a point to visit Ghana as the first African country when he became president of the US, just to tell the other African countries that this is how we like you to behave. I'm not going to go into some of these ones because it coincided, like I said, with a period where democratization was taking place in sub-Saharan Africa. And in the case of Ghana, healthcare reform became one of the major issues in political campaigns. And the particular party that won these elections made it a point, within the first month of its office, they made it a point to tackle the healthcare system. It started off with challenging the current cash and carry system, showing how costly it was and how ineffective it was in terms of providing services to patients. They ushered in what they call the National Health Insurance Scheme. This is yet another one that it came in through a bill that was introduced and passed in 2003. And with the National Health Insurance Scheme, they had three types of insurance. The District Mutual Health Insurance Scheme, they also had the Private Mutual Health Insurance Scheme, and the Private Commercial Health Insurance Scheme. Of the three schemes, the one that is most popular is the District Mutual Health Insurance Scheme. That is because it is heavily subsidized by the government, which again brings up that issue. It raises some questions in terms of how is the government going to be able to fund this program. In the paper that we write up in this, on this particular study, we highlight some of these accounting details that are surrounding those issues. I'll give you a very quick example of what you will find in some rural areas. Since this scheme came in, it is very common in most rural areas to find something like what I have there. That is the West Gonja Mutual Health Insurance Scheme. And all rural communities are encouraged to have these health insurance schemes. That is funded partly by the government. And in the form of revenues from taxes, they also have funding coming in the form of Social Security contributions. The interesting one about Social Security contributions is the fact that a large proportion of the population works in what they call the informal sector. These are people that don't have like a formal position that can be taxed and that type of thing. These are people that on a daily basis will make their living either on the farms or in the markets. And they also have premiums that will be coming from individuals. At the time that we did our interviews, the average premiums was about the equivalent of $6 per person per year. And this was going to help fund hospitals. Now, some reflections. We've looked at all three reforms attempts that have been made, some reflections. Now, as accounting researchers, what we find in this particular project is that accounting and other financial practices are providing justifications for the macro level health sector reforms. We see situations where the government would use accounting professionals to provide them with projections about how much revenue will be generated and how successful the particular reform project policy is going to be. Quite often we see that this does not play out the way that accountants talk about it. Secondly, we also find that global agencies like the World Bank, the World Health Organizations, and UNAIDS are key actors in the field of healthcare policy making in Ghana. They provide all kinds of support, including financial support, including capacity building areas. But what we find in terms of the outcomes of this support is still a situation where the picture is very dire. Finally, major challenges we see at the individual hospital level, especially relating to cost tracing. As accounting researchers, what we're trying to look at is, if you say patients should pay for the services that is rendered to them, how are we able to track the cost and resources to individual patients to ensure that we are not ripping them off? And these were some of the issues that we find in the project up to this point. It's still ongoing.